you didn't see me last week.
And it
So
didn't rain, did it?
it did, it did. So the shamans were pretty happy. So we had shaman sessions,
Hmm.
and they were saying it was a blessing for the ones who attended over there. So there's meaning behind it. So we've had a good session with Native American Indians also, and also some herbs that I definitely want to get into, because as part of our experience is actually immersion, meaning experiencing what we're teaching. So today we're going to be talking about the herb named kratom. So this is not new, but it's actually becoming a little bit of a norm, especially in Arizona, because we actually went to what we call kratom bars. And this is actually in multiple cities, not only in Arizona. They offer kratom teas, kratom mocktails, kratom energy style drinks. And you can actually see that the crowd there is almost like a dispensary. Everybody's happy, everybody's just so chilled out and leveled.
It's a
And
hallucinogenic, you know.
that's right. So, and
It's
that's
it's
why,
it's allegedly safe, and these guys were dropping dead with using this stuff.
well, true. So, but that's why now we're going to get into the science behind kratom. So, again, once something is served in cafes with menu, patients assume it's safe and often don't disclose use unless asked. And I also see this in clinical practice now with patients presenting me, is it safe? Is it good? What is it? Right? So, let's go into a little deep dive into what kratom is. So, kratom or Mitragyna speciosa is a Southeast Asian botanical containing active alkaloids, primarily mitragynine and 7-hydroxymitragynine. Mechanistically, it's a partial mu opioid receptor agonist. Adrenergic and serotonergic activities have been found in this herb, and also strong dose dependent pharmacology, which is always related to an opiate. So that's what they're kind of relating it to. So important distinction here is kratom is not an opioid, but it is clearly an opioid receptor agonist. So that's what it does. And at low doses, kratom behaves less like a sedative, but more of a stimulant. So this is what I guess, the bars were made for. This is more for socialism. This is more for lowering anxiety and depression. And you interact with people of how like-minded you are in one roof. So us fellows went in there and actually experienced it and actually saw the whole party going on, but more of a, let's put it in a more scientific perspective. So reported effects of kratom includes improved focus and alertness at low doses, right? And it increases sociability, reduce anxiety, improve mood and energy. And again, RCTs, not much. There are some few that I will cite today, but more of this will be done in animal models, suggesting anxiolytic and antidepressant-like effects, likely via the monoaminergic signaling. So human survey data consistently show for patients using low-dose kratom for mood regulation, energy support, and psychological coping, not intoxication. So human data, as I mentioned to you, again, we do not have much controlled human data, but a 2020 randomized double-blind placebo-controlled trial published in the Journal of Psychoactive Drugs examined regular kratom users using a cold presser test. So that's where you put your hand in a very cold bucket of water and times you in terms of how long you stay in there and release it. So findings were pain tolerance increased from 11 seconds pre-dose to 25 seconds 1 hour post-kratom. Placebo showed no change. This confirms measurable analgesic effects, not just subjective reports. Risks are real and dose dependent. Dependence with daily or escalating use will happen. Withdrawal symptoms, nausea, constipation, sedation at higher doses. Most adverse outcomes occur with high doses, concentrated extracts, and polysubstance use. So when you're partying, when you're going crazy, you're using alcohol, benzos, and also opiates along with it. That's when the trouble starts. So clinical takeaway here, kratom sits in a gray zone, not benign, not equivalent to prescription opiates. Our role is in endorsement or condemnation, especially we are now going to be educated about this when we see it in our clinical practices. So it's risk stratification, dose awareness, and patient education. If patients are drinking kratom socially, we should at least know why, how much, and how often. So bottom line, low dose stimulant, mood, and energy is produced. Higher doses, analgesia, sedation, and even addiction sometimes. And bars normally uses this, and sometimes disclosures are not there. So clinical conversations matter more than ideology. So thank you, and I hope that kind of opens some light about kratom for us clinicians.
They think it's serious enough to where they can now test for it. also.
In blood testing?
Urine test is, I know for sure.
Oh, I'm not sure. So
Yeah. Oh yeah.
we didn't get tested in Arizona.
You
So
know, did you try it?
I tried it.
Yeah.
I was
Amen.
dancing like a
That,
shaman. I'm kidding.
that is that why your hair's all mussed up tonight?
No, I forgot my to comb. The wind's so strong here, so that's the only reason why.
Okay. Okay. Yeah, 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 yeah. You know, this is the poor man's hooch, you know, that you can buy it in a, you know, in a smoke shop around here.
Oh, don't you know they don't only sell kratom there, but also kava. So these bars are getting a little bit more dynamic. So they're combining stuff.
You
But
know,
again, it's
you're gonna
immersion,
go
it's
you're gonna go
educational.
to Dubai, they have hookah bars on every corner, you know.
Oh, true. Oh, true.
So
Fun.
I told you I've been there already. All right. Well, Dr. Mitchell, thank you for coming back to regale this ragtag group talking about kratom. You know, last week we talked about battlefield acupuncture. You know, it was something useful. So
Hey, it'll be
Obviously,
useful in the
everything's
this is
future.
useful in
this
its
is
own way.
so
Yeah.
so you don't notice, Dr. Mitchell, or maybe you do, but Dr. Menario is taking the integrative medicine fellowship at the University of Arizona, and this is what they're teaching you to go to bars.
And don't forget the prostate tidbit that I mentioned to you.
I'm glad they've got shaman medicine, or I don't know how to term it, as part of their curriculum. I think that sounds really cool.
It is. So we even
Shamans.
did some ceremony to us. They kind of herbs, they kind of smoked around us. So they kind of wanted us to immerse also in the Native American culture. So that's why this is a different level of integrative medicine. So we always know about stem cells, right? Supplements, but this one really goes down to the basics. And even heritage integrative medicine, cultural heritage medicine is covered by this specific curriculum.
Mm.
I think this is only going to grow. I can tell you that mitochondrial research is now looking at some of these shamanistic rituals and seeing how they can affect mitochondria. So we can go into that maybe in the after session.
Okay.
Yeah,
Great.
cool.
Okay.
Okay.
Oh,
Okay.
Siobhan, you're asking for it. You're gonna get booked.
Yeah, you're gonna is John on? I don't know, see if John's on tonight. Okay.
Okay, so I'm
Doc,
gonna try to share my screen. Hopefully you guys
should I,
will see everything and it'll look great.
should I introduce you or just skip
Oh
right
yeah, yeah, please
to
introduce
it?
me.
Okay. So
I'm so shy.
uh everybody, this is Dr. Siobhan Mitchell, who's been on with us before, Chief Scientific Officer at MitoQ, completed her PhD at SUNY Albany, um, and a postdoctoral fellowship on brain aging at the University of Washington. You know, I was at SUNY Binghamton for a while. So, uh, Dr. Mitchell held roles at the three largest food companies in the world, Unilever, Nestle, and PepsiCo, leading trials in Europe, North America, and Asia, investigating the effects of nutrition on cognitive decline, mood, and performance. Um, Additionally, she was senior. Did you come up with anything, especially when they started coming out with the diet stuff and
Oh
cognitive
yeah,
decline?
yeah. I,
But if you worked for
I
them,
could go on about
if
noon,
you
but I
worked for
will
them,
not
you
do that
had to
right now.
hide it, right?
Yeah, pretty much.
Okay, all right. Uh, I can see that's how I get myself in trouble all the time. Leading trials at North America, investigating effects of nutrition on cognitive decline, mood, and performance. She was the senior director at Noom. I tried that for a while too, but they were annoying. You know, you have to type in every single thing, 8 times a day. It got to be too much. Where she directed a team investigating weight loss and mental health digital programs using cognitive behavioral therapy and methods. Dr. Mitchell has given talks on nutritional neuroscience at conferences all over the world, authored over 80 papers, holds 8 patents for aging, cognition, and mood products. And and she's been with us before, and it's always fascinating. And so, Dr. Mitchell, she's going to talk to us about mitochondrial therapeutics. So take it away.
Yeah, so thank you. And in fact, I just have this blurb here because my team is always saying I don't talk about where I'm from and what I'm doing, but you basically said all these things very nicely, so thank you. All right, so now I'm just going to get into a little bit of basics and probably move quickly past this. So I'm going to talk to us about the mitochondria kind of mechanisms on basic aging, but I also want to bring them to how is that going to look like in terms of diseases of aging, and also how you can think very preventatively. So how do you look at your mitochondria in the earliest stages of chronic diseases and extend that health span? And so just to kind of get everyone on the same page, mitochondria, of course, are important for ATP, but they're also doing, I would say, almost a CEO role in the cell. So they're behind so many other things that the cell is doing, like calcium, apoptosis, stem cell regulation, and particularly immune regulation. And I'm going to go into this a little bit more in this presentation because I think this has not been given as much attention about how you could target mitochondria for better immune responses. This is a very fascinating trending field right now. So just to also give us a sense of where we think mitochondria are in terms of a really early indicator of aging, it is so early because we have lots of data showing that mitochondria start to dysfunction at around your 20s and 30s. And the best example, of course, is in your muscle. So everyone's aware that your muscle, your function in terms of exercise and peak performance is optimal around your 20s, early 30s, and just starts to go down. And this is because you're actually having less ATP production in your muscles and also less mitochondria copies in your muscles starting from age 30 and then going on to age 80. So this is, I think, one of these things that everyone always accepts. And I don't know if we have to always accept that. I think we should pay a lot of attention to how we can work with our mitochondria best to have this minimal effect on our muscles and the way that they're producing energy. So the one thing, though, is that there's a lot of things that can cause our mitochondria to dysfunction. And so there's innate things like just the fact that you're making a lot of oxidative stress in your mitochondria. I don't have to tell people about that whole mechanism because I think everyone's really aware of it. And the fact that we're having a lot of inflammation occurring in our bodies as we age, and the fact that we have metabolism issues like poor glucose control, et cetera. But then there's also a lot of things that we can't control very well from our environment. And these are things like, microplastics and various infections and even molds and toxics or pesticides and heavy metals that are particularly affecting our mitochondria. So I think people are always imagining, okay, where are we going to look at something like an immune response in terms of like a mold infection? Like that's one thing, but you should also look at your mitochondria. And just to bring my argument home even further, the way that I even think about these other hallmarks of aging, and so we are aware that there's about 12 of them currently, there's probably going to be more added on. A lot of them can actually be shown to be due to a mitochondrial dysfunction root cause. So for instance, telomere attrition, well, telomeres are really being caused to shorten prematurely because of things like oxidative stress. Other areas like, looking at cellular senescence is due to the fact of like lower ATP production, lower NAD production, mitochondrial DNA damage. So we could just go on and on about all the different ways that mitochondria function are contributing to these 12 hallmarks. And then to just sort of raise my point from before, when we look at these aging mechanisms, we can then start to see that mitochondrial dysfunction can be causing the basic sort of early mechanisms of type 2 diabetes and cardiovascular disease. I won't go into all those during my presentation today because it would take too long. But yeah, come to me or email me afterwards if you want to hear about some of these. I will be diving into some of this for cardiovascular disease, though. And so I thought what I would do is, since I'm not going to go into every single root cause of mitochondria in an aging related disease, I would bring up one that I think kind of takes really strong precedence these days, and that's mitochondria effects on our immune response. And so particularly things like COVID and then also long COVID and also other things that immune response can have influence on, like for instance, amyloid production in Alzheimer's. So there's a lot of data coming out these days that even how much amyloid you're producing is because of some of the ways that mitochondria is modulating our immune response in our cells. And the way this is mostly happening is through a C-gas sting pathway, which helps release cytokines from immune cells. And so what's going on is when you have an infection like COVID or some of these ones that are related to Alzheimer's, like HPV, what is going on is your mitochondria are producing boroxide stress because of that infection. They're also releasing mitochondrial DNA. And because mitochondrial DNA are considered foreign because they're obviously originally their own cell, this basic sort of response to seeing this different DNA is to have a cytokine kind of reaction. And this involves the NL3P3 inflammasome. And when this is, I think, kind of, I would say, under control, this inflammasome can then get resolved and everything's fine. But when it's not under control, which often happens in things like, for instance, long COVID, or in the case of inflammaging and Alzheimer's, you get this inflammasome that's going on, that's being turned on because of this mitochondrial DNA release that's always on, and you get amyloid overproduction to the point of plaques, etc. And so there's a lot of things that can make mitochondria go wrong, as I mentioned before. And so what I'd like to talk to you today about, how can we keep it going the right way? And I have devoted my career to looking at mitochondria, especially for brain function. And I have found that there are some nutrients that seem to be pulling more of their own weight. So I have listed them here. So omega-3s, obviously B vitamins, ketones, ergothioneine. I don't know how much you've heard of these before, but I would like to focus on some that I think are especially really important for the present sort of topic and the results I want to talk about, which is PQQ, mitoquinol, also called MitoQ, and NAD precursors. So I'm going to start talking about NAD precursors, but I'm not going to go into depth either because I'm sure you've had discussions about these before. So NAD, of course, is very important for mitochondrial function because this is really how we're making ATP through the electron transport chain. But there's also many other roles that it has in cells, and especially around activating sirtuins that can then invoke a lot of cellular pathways that are good for using energy efficiently, I think is the best way of putting it, and also for things like DNA repair. So we all know NAD is important. We want to keep it up as much as possible. And what is interesting is all these NAD precursors and what they're delivering to us. I think you could try to talk about NAD is, all right, if it's getting a certain amount of, NAD increase in the bloodstream from something like NMN or NR or even nicotinamide, it must be doing its job in terms of then going and having these good effects on your mitochondria. But that is not true. This is something where I think there's a lot more to be understood about how well some of these NAD kind of precursors are helping NAD be used more efficiently in the mitochondria. And so, for instance, when I see some of these kind of, I would say, claims coming out here, like there's an MMNH, which is now being marketed as a more active form because it makes more NAD in the plasma. I don't know if that's enough for me to believe in it. I would need to see more clinical trials in it, which I have not seen yet. Another important mitochondrial nutrient is PQQ, and I have not heard a lot about this in the US, which is interesting because I'm based in New Zealand, and so I hear a lot about what's popular in Asia, and this is extremely popular in Asia. So PQQ is a mitochondrial antioxidant that has various roles in mitochondria. So for instance, it can help enhance NADH oxidation and also can help with mitochondrial biogenesis. But what's really interesting about this particular molecule is it's very good at getting into the brain. So I think that's really important. So it can get into the mitochondria, but can also get into the brain quite effectively. So it's been researched a lot for things like improving cognition in young, healthy people and also older people. So I think, a nutrient. What I would say is anyone's having brain fog, if anyone's having kind of poor sort of cognitive ability in various kind of aspects, like they should think about PQQ as a way to target mitochondria. What I would say though is that when you look at all the different kinds of mitochondrial nutrients that are out there, I would say that mitoquinol seems to have the most data in terms of clinical results. So I'm going to do a little bit of a deep dive on mitoquinol. Is something that I think can not only be very complementary to these other ones I just mentioned, PQQ and AD boosters, but can also take over the roles as well. So for instance, mitoquinol can activate sirtuins. It's also a very powerful antioxidant. It can increase, I would say, a lot of these problems with, mitochondrial turnover. So it can help with mitophagy and also help with biogenesis and also decrease DNA damage. So I'm just going to sort of quickly just set the stage about how this is all working. So MitoQ is what I would call a mitochondrial targeted antioxidant. So it was designed about 25 years ago by Mike Murphy and Robin Smith in New Zealand, where they were trying to solve the problem of CoQ10 being a really effective mitochondrial antioxidant. But when you take oral CoQ10, it does not get into mitochondria that well because of its large size and its hydrophobic nature. So what they said was, all right, if we can put a special tag onto a CoQ10 moiety, then maybe we can have something that delivers a lot of antioxidant benefits to the mitochondria. So they designed MitoQ using a triphenylphosphonium tag that was very positively charged, so it helps get into the negatively charged mitochondria. And they saw through basic cell experiments that it obviously prevents a lot of oxidative stress being formed, especially when the cell is stressed, but also protects the membrane against damage and upregulates antioxidants that are important for, kind of endogenous mitochondrial protection. And that's including protecting against DNA damage. And more importantly, it helped support ATP production, especially during those times of stress. So things like hypoxia, things like infection, all the rest. And so now I just want to dive into one area that MitoQ has been shown to be very, very effective in, and that's showing, I would say, improvements in flow-mediated dilation in diverse populations. So I wanted to have a little bit of a primer on what flow-mediated dilation is, because it's not commonly used in the clinic, but it is a biomarker that seems to be more effective in predicting cardiovascular risk than almost all the traditional biomarkers you can think of, including hypertension, BMI, hyperlipidemia, family history. So it seems like FMD, if you have a poor FMD, according to your age, this is a really big predictor that something is wrong with your vascular system, and it could be mitochondrial origin, and this is where you should focus on your mitochondria. And so just to go into some of that data, one study that has come out in the last 2 years, and I'm really going to only go into not that 29 clinical studies you saw on that chart over there, but just about 6 studies that I think are really pivotal that all were published this last year. And one of them is looking at flow-mediated dilation in postmenopausal women. And so everyone here is aware that there's a lot that goes wrong when you reach menopause. So you lose estrogen, and estrogen is very important for mitochondrial function. So estrogen is helping support not only the growth of mitochondria, but also the oxidative stress produced by mitochondria. And so what is really seen is when you lose that estrogen at those kind of last stages of perimenopause, vascular health starts to deteriorate. And this seems to be due to the fact that the nitric oxide release that is required to have, optimal vasodilation, that is, basically what is being measured by flow-mediated dilation, this goes down, and this is due to the excess oxidative stress that's occurring in the mitochondria that then seems to block this nitric oxide release that should be happening. This study that I'm showing you right now that was done at University of Colorado was very interesting in the fact that they wanted to understand if you had a late menopause, so a late menopause is age 55 or older, are you having better vascular health than women who have a normal menopause? So not anything kind of like surgical menopause or, ovarian insufficiency, but just normal menopause. And what they saw was that the FMD, the flow made dilation, was better if you are having that late menopause, that you have just even a few more years of estrogen and progesterone in your system. And so then they had the next question of, all right, what happens if you use a mitochondrial antioxidant like MitoQ to try to address that oxidative stress that might be the reason why they're having this vasodilation problem? So they used just one dose of MitoQ, used an acute dose of 160 milligrams as a proof of concept study. And they gave this, and then an hour later looked at flow mediated dilation, and they saw that there was an improvement to the point where normal onset women and late onset women in terms of menopause start to look more like their premenopausal peers. So I thought this was really remarkable because in this study, they also showed that, these women, after they got the MitoQ, also had less oxidative stress. They had better lipids as well, too. And it was interesting, they kind of pinpointed palmitic acid is one of the lipids that seem to change most of all during this kind of postmenopausal transition. So that's something also that I think probably deserves a little bit more effects in terms of understanding how that's working, why mitochondria seem to be important in that way. But now they're following up with a much bigger study looking at a chronic dose of MitoQ, and they are hoping to publish it this year, and that will include about 100 women. So I think this will be a really important step for having women be aware that menopause, it's got a lot of things that people are aware of in terms of symptoms, like just the overall vasomotor situation, but they should also be thinking about their cardiovascular health in the long term, because this is now going to be decreasing. And if you're not going to be taking HRT, you're going to have issues in terms of your risk for even things like hypertension and high cholesterol are going to go up quite a bit. And then I would say another study that came out this year that was also really interesting to us was a study looking at flow mediated dilation for people that do not exercise regularly. And I'm sure you have patients that are really not that responsive to exercise and they don't like it or they can't get into the habit of it. What was interesting in this study was that in kind of a similar manner, they used a kind of concept study of looking at 80 milligrams is just one dose that they gave to non-exercisers. And then an hour looked at their flow mediated dilation and saw that this improved, and that also people felt like the exercise was more fruitful with the MitoQ. So what I think is really interesting about this is just this idea of, if you've got people who are sedentary that don't like to exercise, this is a way that you can still preserve their vascular health and perhaps also get them to be a little bit more excited by exercise in the future. And we also have lots of studies showing that MitoQ is good for exercise in terms of overall muscle output, in terms of power, in terms of exercise performance, like in time trials. I always feel like these are nice to mention, but I don't know how often people are really trying to get like their personal best in exercise. I think they're just trying to make it easier. So I think this study is a good indication of, you might be making exercise just a little bit easier, which I think is a huge benefit, especially as you get older. And then this study right here, I have to say, is our newest study. So bear with me, this has not been published yet, but this is the biggest study we have ever done with mitoquinol. And this is where we used 179 participants to look at how MitoQ could be helpful for liver health. So we basically enrolled these participants who had concerns about their liver health. It wasn't like they'd been diagnosed with anything, so they didn't have any kind of actual fatty liver disease, MASLD, or anything like that, but they just had that feeling of like, my diet's not great, or, I know I'm under a lot of stress and I'm worried about my liver. And so what we did was we then gave 12 weeks of MitoQ at 20 milligrams. And we saw that ALT was decreased by 7.5 units per liter with mitoquinol compared to like a four unit decrease with the control group. We didn't see as much change with AST, but I want to also just make sure that you guys are aware this is a healthy population. They were not someone that is being diagnosed with any kind of liver disease. So I think once again, in that kind of preventative vein, if you've got people that are concerned about their liver, concerned about, how much damage they've done from whatever they did in the past, or even what they're doing to their liver now, because, we can't always control the things that we take into our body, that this is like I think a maybe good sort of preventative measure that you can just kind of add on to your sort of way of living. Because what I feel like is very frustrating about a lot of the issues with liver health is there's not a lot of other solutions besides just saying exercise more, improve your diet. So I recognize there are some medications coming out for things like fatty liver, but I think people are hesitant to get onto that bandwagon. So this is an easier thing for people to be interested in trying. So not only did we see improvements in ALT, we also saw improvements in cholesterol. We're still kind of working all the data out, but this one was more important for if you had poor baseline cholesterol, if you had, for instance, high total cholesterol or high LDL. So I'll be happy to share more results with you in a little bit. But we also saw that using some of these classic questionnaires like the perceived stress scale, the Childhood Fatigue Scale, that there was also improvement in perceived stress and overall weakness, so i.e. fatigue, and also concentration was improved as well too. So I think this is where, people, when they take something like a supplement, they sometimes realize this is just good for my overall health, it's good for my overall aging, but they also want to notice a benefit. So we're really excited to see that this is something that people can notice as well too. We also looked at some other kinds of indicators of high inflammation. So things like lymphocyte percentages, RDU-DVD, WBC. So we know these are things that, are always being checked in a physician's office. And we saw that those who had higher baseline sort of inflammation or kind of, immune dysfunction were showing even more effects of mitoquinol on things like ALT. So this study, I think, was also another really exciting study for us this year, because this is the first study that was showing how mitoquinol can be beneficial for people with diabetes. And this study focused on how, for instance, people, when they have diabetes, they usually get a lot of clinical care in terms of their blood glucose control, and then maybe a little bit of a cursory kind of, let's check your cholesterol, let's check a few other sort of cardiovascular risk factors. But what can happen quite often, honestly, like more than people realize, is that while the diabetes is being controlled, a lot of the oxidative stress can then bring on damage to the heart that might not be perceived unless you're having patients get echocardiograms, which, we all know are a little bit more effort and not always being called for. So this study in particular wanted to look at how you could use mitoquinol to prevent heart damage. So basically prevent chronic heart failure in diabetic patients. So they gave mitoquinol for 12 weeks at 40 milligrams to those with type 2 diabetes. And then they used an MRS to look at heart diastolic function and also use of energy through creatine ATP ratio. And so I think everyone's familiar with how this works. Basically, they're just looking at, that ratio of creatine phosphate, which is kind of like, when ATP is being used up, versus ATP. And what they saw overall was that this effect of mitoquinol after these 12 weeks showed an improvement in energy production by 15%. So basically indicating that, this heart damage that wasn't being perceived by these patients or even, frankly, their doctors was being benefited by something like mitoquinol over time. So we thought that was really exciting. We also saw that PDSR was improved and diastolic function was improved in both resting and stress-induced states. So this seems to be an overall really beneficial kind of supplement to use for people with diabetes. And then maybe also what we're hoping to do is now seeing this effect that maybe we can look at, this kind of heart function in people with cardiovascular risk factors as well too. And so then lastly, and now I'm going to move into this sort of immune function role of mitochondrial antioxidants. And this is where I mentioned earlier that mitochondria do seem to have a really important role in immune response. And so in the situation where people had been exposed to SARS, to COVID, through either a family member or a close colleague or something, were enrolled in a study, kind of like, once again, a proof of concept study, to look at whether after getting that exposure, could mitoquinol decrease the level of infection, so the sort of rate of infection, and also the level of symptoms if they did get infected. So in 40 participants who took 20 milligrams of MitoQ after getting this exposure, they saw that only 30% got that COVID infection through a positive test, compared to 30 out of 40 that had been just given a control placebo. And so not only that, when they looked at the way that these symptoms manifested in those that did get a COVID infection, they saw there was shorter symptom duration and reduced severity, and also a delayed onset. And so what we think is going on, and this has not been proven in this study because this is just a really quick sort of, I would say, proof of concept study to then mandate a much bigger study. They believe this is through that inflammasome kind of pathway that I talked to you about before earlier. This has been shown in animal studies, so we're hoping to get more data on this over the next year or so. Oh, and then I also want to point out that we're also looking at how long COVID can be affected by mitoquinol. So that's another study that we're hoping to get some data from the next, I would say, 9 months. So this is the one preclinical study that I want to share with you today. And I think this is really important for the overall aging mechanisms that I discussed with you earlier. So it's one thing to look at things like cardiovascular health. It's another to look at, how can you prevent some like really big problems that happen almost like to, a majority of people who reach an older age. And one of these big problems is clonal hematopoiesis. This is where white blood cells, white blood stem cells start to have more mutations in genes that are controlling DNA expression. So the DNMT gene in particular, this is where I think this has now been shown to be occurring in about 50%, over 50% of 80-year-olds. So when you have this clonal hematopoiesis, you are now going to have much higher chance of cancer, clearly, and also poor immune responses, so you'll get more infection. And I think even for people who are younger than age 80, the rate of having clonal hematopoiesis is maybe about 10 to 20% around age 60 to 70. So it's something that I think is not being really looked at that much, but if you can preserve this kind of, mitochondrial function in these stem cells, you can have overall sort of better protection against, not only cancer, but then also have better immunity. So in this particular study, they used a mouse model to look at how with this DMT mutation, if you added MitoQ, does this seem to be helping decrease the amount of cells that had this mutation? And so what they saw was that the cells that had this mutation basically had mitochondria that were overactive. So, and, actually seemed to be proliferating more because of that. But interestingly, when MitoQ was accumulating in these overactive cells, they saw that these cells were going towards apoptosis more. So basically getting rid of cells. And at the same time, the cells that were healthy, that did not have this mutation, they saw overall better function as well, too, in terms of better sort of maturation into, mature cells as well. So I thought this was an interesting one to bring up because this is one of these diseases of aging that there is no good solution for, and is something that, people are only a little bit aware of. So probably there needs to be a little bit more understanding. I think this only usually starts to happen when people are more aware, for instance, that there's a solution for it. So this could be a potential solution. We're now in discussions with this PI to do a human study as well. So we're excited about that. And so just because I've been talking about a lot of these studies, I want to just highlight we have this program called the Mitochondrial Collaborative Research Program, MCRP, where we're happy to offer mitoquinol test products, placebo, or powder used for preclinical studies to any researchers that are interested in looking at a kind of mitochondrial function or a disease or condition that they think has a mitochondrial role. So right now, I think we have about 20 different studies that are ongoing. You can go look them up at clinicaltrials.gov. But, we find that it's really exciting how much mitochondria seem to be important for basically everything. Right now, we have a study that's looking at, for instance, PTSD. So looking at how PTSD affects vascular function. So this is another area I think people are not always aware of. And that, maybe mitoquinol can be used to help with the vascular dysfunction that's associated with PTSD. We have another study that's looking at, for instance, stroke rehab using mitoquinol, so helping improve gait function, and as well as, various kinds of quality of life measures. And I can just go on about all the different studies, but I just wanted to give you sort of an array of some of the ones that I think, you might not think would have a mitochondrial kind of application, but in fact do seem to be something that mitochondria can affect. All right, so now I just want to go into some of the clinical applications of some of those mitochondrial therapeutics that I mentioned earlier. So the NAD precursors and PQQ and mitoquinol, because I, for instance, was very interested to try to understand, there's a lot of excitement in the news about things like NAD precursors, and then we're not always sure about, what are they actually being shown to be clinically useful for. So I wanted to put that together. So I'll start off with PQQ, where I basically just looked at all the different studies that have been using PQQ and what kinds of effects that were seen with them in terms of the dose and then also the population. So what was seen overall with PQQ is, as I mentioned before, it seems to have pretty robust effects for cognition. So not just young people, but also old people in various cognitive domains like processing speed, cognitive flexibility. It also seems to be, useful for things like hypocholesterolemia. People who have insomnia did report also having improvements in sleep quality. It has overall good effects for inflammation, so C-reactive protein, and also has been shown to improve blood flow, which might be one of the reasons why it's also helpful for cognition. That has not been looked at as much. So this one, I think, the overall cognitive data is the strongest. So I would say if people are coming in with, as I mentioned, mental fatigue or just cognitive issues, PQQ is something to try. For when I looked at NMM and NR, I was surprised how little data there is. So I know people say subjectively that they're noticing a lot of effects of NMM, but in the end, I would say they're not really that strong. So for instance, NMM, the main results have been seen in terms of sleep quality in elderly, improved insulin in pre-diabetics, improved hypertension, with quite large doses, so that's something to be aware of, and also peripheral artery disease. When I looked at NR, I was very disappointed to see that there was actually not that much data on any, I would say, more kind of common clinical feature. So there was some data showing for people with COPD that there's a little bit less inflammation. Once again, another effect for peripheral artery disease. An effect in terms of mitochondrial function in heart failure, but not really showing any kind of, I would say, functional benefits. And then also some, sleep improvement in terms of sleep metabolic rate. But then once again, I feel like this is really subtle. It's really hard for people to, I think, notice something like that. And there's no kind of subjective improvement in overall sleep. And so the other thing I tried to do is look at some of the ones that did not show any effects. And so, for instance, NR had several papers come out in this past year, in 2025, showing no effect for long COVID, no effect for hypertension. It's, I think, being a little bit more challenging for us to really understand how NR can be beneficial. I still feel like it has benefits, but I think it's really clear that, it's maybe something that probably would be more useful in a combination therapy, for instance, or something that seems a bit more targeted for what it's doing. And then just lastly, I wanted to summarize some of the things that have been seen with mitoquinol. And yeah, these are things I didn't mention particularly in this presentation, but just so you're aware, it seems to be helpful for early signs of cardiovascular disease, in particular aortic stiffness, and then also hypertension. It seems to be useful for diabetes in that sort of diabetes cardiovascular protection study that I just presented. It also seems to have effects for peripheral artery disease and heart failure, very similar to the NDD precursors. But then moreover, it's been shown to be effective for fibromyalgia and also chronic fatigue syndrome in terms of subjective effects in pain, and then also cognitive improvement. So then lastly, I showed you some nice liver effects, but we have also seen that it's useful for hepatitis C as well. So it can improve ALT in people with hepatitis C. And also for those with kidney disease, it can improve overall vascular health as well. So these are, I think, what I would call the areas that we do have conclusive data. I wouldn't say conclusive, actually, that's not the right word, but some data showing that, there is some clinical applications. And I hope next year I can show you a lot more. So these are some of the references, and I think, it's probably about the right time. So I am happy to discuss any questions.
Yeah, first question I have is on the last slide. Was that with the dose numbers? Is that daily?
Yeah, daily. Yes.
Okay.
Oh, and one more thing I just want to point out. This has been something that has been communicated to me just in the last week. So this is very preliminary, is that large study I told you about that was looking at FMD in a large cohort of 100 subjects. They have been reporting cognitive benefits in that one, so improved memory. And this is people who are older, so age 65 and above, who are not having any kind of diagnosis of cognitive disorders, MCI or Alzheimer's, but have seen that through some cognitive testing that they are seeing especially verbal memory and also visual memory is improving.
There's a question of someone with thalassemia, mildly elevated AST or ALT less than 2 times normal. Any benefit from MitoQ?
I think maybe there would be a benefit for ALT. I don't think we have, we might have some preclinical data supporting a thalassemia application. I would have to check.
Next question. What about side effects and any dropouts from the studies?
From which study? Or from any of them?
Yeah. Mm-hmm.
Yeah. So the main adverse effects that have been reported in clinical studies have been gastrointestinal, and this is just, mild nausea, mild stomach upset, usually something that, goes away after a few days. So, usually in clinical trials, it's something that, the patients report at first, the subjects report at first, and then it goes away. In terms of dropouts, I think there's been very few dropouts in any of these studies in terms of, the actual sort of symptoms or side effects. Usually it's just dropouts due to, the usual reasons, just disinterest or, motivation. And our customer data, I would say the most common thing is also gastrointestinal side effects. And then after that, headache. But to me, I'm never quite sure if people are really having a headache due to MitoQ or it's maybe just something that is, more coincidence. It's hard to say, but usually we just tell people if you're having any kind of issue at all, just either go the lowest dose that you can or just take a few days break from it and then try it again. So, and of course, we don't always follow up as well with our customers, not as well as we do with subjects.
The question about, is this similar to urolithin A?
This is really different from urolithin A. So urolithin, I actually did research in urolithin A when I was at Nestle. That is a pure mitophagy mechanism. So urolithin A is very good at improving mitophagy. I'm not convinced that you want mitophagy to be happening all the time. I think mitophagy might be one of those things that you would benefit from getting a boost from, time to time, but maybe not something that you want regularly. So that's how urolithin A works. Mitochondrial is working through this antioxidant mechanism. So it looks a lot like a CoQ10 molecule, except for the fact that at one end, it has this tag that I mentioned before that is positively charged, and that allows it to get into the mitochondria. So the main thing I want people to understand about mitochondrial that makes it rather unique is that it can get into the mitochondria up to 90%. And almost no other supplement can get into mitochondria in that same level. For instance, oral CoQ10, maybe about 5% of it will arrive in the mitochondria. And I was just reading a recent study where they gave CoQ10 to older subjects and they saw absolutely no improvement in mitochondrial function whatsoever. While MitoQ has been shown to improve mitochondrial function. So things like, in humans, mitochondrial membrane potential and decreased oxidative stress. The other thing that I also want to point out about MitoQ is that it's, I would say, like a mild uncoupler of mitochondria. So I don't know if you guys are aware of this idea of the mitochondrial redox theory of aging, that you want a really balanced amount of oxidative stress. You want some oxidative stress, right? So I think everyone's aware that, oxidative stress in itself can be a really important signaler, but you just don't want it to be an overload. So I think that's another sort of area that MitoQ really excels in, is kind of keeping this balance of oxidative stress by controlling how much the mitochondria are going to make energy overall.
What is MitoQ derived from?
It's not derived from anything, it's purely synthetic. So they take basically an idabenone. I don't know if you know what idabenone is. It's like a shortened version of CoQ10. And they attach this triphenylphosphonium tag through, a chemical reaction. So yeah, it's not found in nature.
Okay. Do the doses that you're showing here continue after the symptoms improve?
Yeah, so I would say the main way to use this is to address these symptoms and then try to go down to a maintenance dose if possible. So the great thing about mitochondrial is it can accumulate in your mitochondria. And then once you get to a steady state, it's just doing its job. It gets recycled the same way CoQ10 does. So I would say, yeah, like you don't need to give people a huge amount to start getting an effect, and you don't need to keep it at that same level to have the effects stay. There's no kind of adaptation, if you will. The other thing that's interesting about mitochondrial is it seems to plateau in terms of the amount that it'll accumulate in cells. So at some point, these cells will turn over, or the mitochondria will turn over, and then they'll just, exude the mitochondrial. So we haven't really had any effects that seem like, due to some sort of toxic overload of mitochondrial that doesn't seem to happen naturally in humans, not at these doses at least.
Does increasing CoQ10 increase mitochondrial?
No, yeah. So CoQ10 is a totally different molecule in terms of it doesn't have that tag. So if you were trying to measure CoQ10 in your blood and then, see an effect of MitoQ, you're not going to see MitoQ increasing CoQ10 at all. I mean, MitoQ does seem to show improvements in other antioxidants that, are mitochondrial. So we have human data showing that it can improve SOD levels and catalase. We have not seen it improve CoQ10.
Okay. Any biomarkers that would be useful to follow the effects of
Yeah, so I mean, some of those I mentioned, um, in terms of biomarkers that I think are easiest to do, like probably blood pressure is one. So we have a lot of people that are using it for that. And then, any kind of marker inflammation that you can think of, right? So MDA, IL-6, that type of thing. So yeah, that's probably the easiest. I often find that biomarkers are one thing that you can do, but then asking a patient if they're noticing an effect is another. And that's where we get people, I would see the most kind of benefits of people feeling like this is really adding to their health is that they feel like more energetic and they have, yeah, as I said, less brain fog and kind of feeling of like, that they can't get through their day.
Mm-hmm. Okay. Dr. Antoli asks about NT factor.
About what?
NT factor, capital N,
Um,
capital T. That's, I think, Dr. Ross Pelton. I think that's one
Yeah,
of.
these are phospholipids, so it enhances your cell membranes. So
mhm.
for cell transport.
I don't think I'm aware of any data on that at all. So
Okay.
no idea.
All right, we'll have to get him on that. What about cost and availability?
Yeah, well, this is something that you can get from FullScript very easily. I know some people don't like FullScript, so you can also go to mitoq.com and there's a practitioner portal. And through that practitioner portal, you can get, a very discounted rate for the practitioner brand. So we have a practitioner brand where you can get 20 milligram capsules, which we think is, the most useful clinical dose at around $60 per 1 month box. So yeah, and then if you order a whole bunch of them, you get multiple discounts. So it usually works that way.
Okay. Can you take coenzyme Q10 and MitoQ together?
Oh yeah, yeah. And in fact, we have a lot of people that do exactly that. Just because the one thing I probably didn't mention is that CoQ10 is very important for the electron transport chain. MitoQ does not substitute for that. So it is not actually helping transfer electrons the same way CoQ10 does. So
Mm-hmm.
it probably does help to take a little bit of CoQ10 with mitoquinol, though once again, we've never actually done a study combining them together.
Okay, we got
I think let me cite a protocol there. I think this is done by Dr. Mark Houston, the integrative cardiologist. So he always suggests that when you take cardiac mitoQ or cardio mitoQ, you always need to have a regular CoQ10 for the same reason that Siobhan mentioned, that it doesn't work the same. So that's why when you prescribe mitoQ to your patients, you make sure, especially with these organ-specific mitoQs, you always need to add your extra CoQ10 or ubiquinol.
Yeah. Yeah, and I would say just in addition to that, CoQ10 has roles obviously in other places in the cell, like lysosomes, and yeah, mitoquinol is not engineered to go into those areas. It's really just mitochondria.
Okay. Are you familiar with Steven Sinatra's protocol for post-cardiac events? Uh, he was one of my first anti-aging teachers, and he uses. Let me think if I can think. Coenzyme Q10 with PQQ, um, magnesium, acetyl L-carnitine, and D-ribose. Now he passed away about at least 5 years ago, so this was probably formulated in the early 2000s. Any usefulness, adding or substituting, what you're talking about to that because I've used that a lot.
Yeah, I mean, it does make a lot of sense to me in terms of that formula you just mentioned, and then also bringing MitoQ into the mix. I think, as I said before, if you look at any other supplement out there, they're not getting into mitochondria at the same level that MitoQ is. So if you really want to have that oxidative stress protection, it's really important to try something like MitoQ to get the most robust effect. Um, we do have We do have a lot of people coming to us hoping to use it for something like a post-ischemia type of treatment, but we have not had any luck having that go on. Interestingly enough, we do have our first Gates Foundation funded study that just started this month for preeclampsia. And I thought that was kind of interesting because there's not a lot of things, obviously, that work for preeclampsia, but they think that MitoQ might be the thing that will do it.
So with all the improvements and all these sort of diverse entities that you've been looking at, the concept of longevity is sort of taken hold in our world. Have you looked at slowing, decreasing senescence in cells, that some things along those lines?
Oh yeah, yeah. So we've never really looked at that in humans. I think that's a little tricky, but we have many, many preclinical studies showing that it decreases senescence, that, it's great for, improving telomere attrition. And it's just one of these things where if you had me talk about all the 12 different hallmarks of aging, I would probably have a study of MitoQ having an effect on that. So the preclinical studies, like there's just so many of them showing all sorts of benefits in exactly those kind of longevity pathways that we know are important, like AMPK activation, like NRF2 activation, like mTOR. So, it's really, I think, kind of exciting to see all that preclinical data about having it hit all those longevity pathways. I guess it's just, as you know, that issue of like, you can mention this stuff, but how do you get the right human data to really give people that sense, this really is something to delay your aging? And so if anyone has any ideas, come talk to me and we can do an MCR pre-program and hook you up with some free MitoQ.
Well, you can find a movie star or
I know.
a football player,
Yeah, or Kim Kardashian seems to be willing to put anything into her body at this point. So yeah.
Dr. Nario, do you have any online questions?
Yeah. So good stuff, Dr. Siobhan. Just to kind of piggyback on your urolithinase, just to orient our viewers here, that it's a natural metabolite produced by your gut bacteria. It's actually from polyphenol-rich foods like pomegranates, walnuts, and berries. And you're right, it is actually famous for mitophagy, meaning recycling damaged mitochondria. And again, this is also one of the kind of leading supplements in relation to anti-aging and longevity. So, but yeah, I think that was something definitely worth looking into in the future in relation to how can it, I guess, interact with MitoQ in terms of the benefits, but you probably need to merge study with the other company in relation to that. So here's the one question that is interesting. So there is, I don't know if you're aware of this, but there is now a project from Canada specifically. It's called Mito Revolution. It's actually a mitochondrial transplantation. It's an advanced technology that they're trying to do. And this is trying to actually transplant healthy mitochondria into damaged cells to restore function and promote regeneration. And I can see where this studies or this project is leading to treating for chronic inflammation, organ failure, right? Mitochondrial disorders. In this aspect, how does MitoQ in relation to this be integrated in such advancement in mitochondrial health?
Yeah, well, we've actually been approached by several of these mitochondrial transplantation companies to use MitoQ to preserve the mitochondria during the transplant, not only in the matrix, but then also after the transplant. So to kind of like keep the mitochondria healthy as, the transplantation has already happened and just kind of smooth the way, if you will. So I think that would be the main way that I would imagine MitoQ could be used. So we're kind of, yeah, I can't talk about this a lot, but we are talking to some of those companies about using MitoQ to help enhance their overall outcomes.
Yeah, that's just mind blowing. I just can't fathom the fact that you can actually get mitochondria and transplanted into somebody else. So I thought it was only
Me too.
organs, but now we're going into the microscopic level of a cell. So Yeah, I mean, if that's something, definitely can keep us posted. Our audience would definitely appreciate that.
Yeah, for sure. No, I actually am also impressed by that too. I mean, it seems so tricky. I'm amazed that they're having good results, at least the ones that they've talked about so far.
Right. So there's a question about the product. So you have different mito cues for eye, heart, right? Different specialty ones. How do you make how do you specialize these specific products to just go to the eyes, to just go to the heart? I know there is a special carrier that you just mentioned, the positive charge carrier tag. Is this also the same technology that you're applying to these specific products?
Yeah, so the only molecule that gets that special carrier is the mitoquinol molecule. But what we did have people basically suggest to us over the years is that, yeah, they would like something a little bit more holistic for something like eye health. So we're never going to say like MitoQ will do everything for your eye. You know, it's the thing. It's more like, okay, for MitoQ eye, like what if we pair MitoQ with lutein, and then we look at how, lutein, which is good at helping with the blue light kind of damage and, blue light filtration, like how that could improve things like eye strain, along with MitoQ and along with, vitamin E and bilberry and all the rest. So we kind of put these formulations together looking at what is the best data for each ingredient, very similar to what we just heard from Bill about, the Sinatra protocol. Just like, let's put these different things together, like PQQ, like the CoQ10, and know that they're going to have, kind of a multimodal effect. So that's the same thing we're doing.
Oh, so it's
We
more
do
of the
have some,
supplements that you mix with it.
oh, like the kind of matrix of it. Is that what you're asking?
Oh no, no, you mix this specific supplement for the eyes,
Yeah,
lutein, as you mentioned, right?
yeah,
Oh,
yeah,
okay, that
exactly.
what makes that what makes up the name, basically, because the compound, the integrated supplements that goes along with the mitoquinone.
I'm not sure I'm like understanding your question. So you're asking what are the different supplements in MitoQI, or where are you
Yeah, yeah.
where are you
So I
going?
think that's that's what's making it special. Meaning it's
Yes.
still the mitoQ, but you're adding for eyes like gluten, yeah, right, xanthan. And then for heart, you're adding D-ribose, for example. Is that what you mean? That
Yeah, exactly. So
okay,
so MitoQ heart is, just things like magnesium and vitamin D and, things that we know are also helpful for the heart, but are not going to be replaced by MitoQ, right? So MitoQ is not going to act like magnesium, but we know that it is important. So that's why we kind of put that together. We do have
okay.
some products out there, like for instance, MitoQ curcumin, where we do have synergistic data, like so data showing that, for instance, if you combine MitoQ and curcumin, you will have overall better brain health in terms of, preclinical models where you'll have more ATP production and, more synapses and things like that. So, but some of these we're just kind of just taking the data that we have from these ingredients and just putting them together based on that.
Gotcha, gotcha. So another question is more better from the sound of it? Not really, because you mentioned that you can start with higher doses and just downgrade yourself to a maintenance dose. Is that correct?
Yeah. Yeah, that's I think what I would prefer people to do because I know it is expensive, but I also know for everyone it's individual in terms of how much effect they're going to get from it. So sometimes you might have to go a little higher at first to start seeing the effect. And then at that point, can you titrate down a little bit to kind of have that maintenance of, the better energy or the, improved hypertension or less inflammation?
So how would you know what is the point wherein you're doing the high doses on a patient, and then now I think it's time for the regular dosing. What are the parameters for you to choose about? I mean, to choose that direction now.
Yeah, I mean it's obviously different for different things. So we have a lot of people that use MitoQ for statin pain, right?
Mm.
So in that case, I think it's just literally like resolution of the muscle pain or fatigue is the main thing that HCPs are looking for. But, we also have Ann Shippey, who's a sort of fertility specialist, who's just literally looking at things like pregnancy rate or hormone sort of levels after using MitoQ is kind of the sign that it's at the right level for, doing the kind of fertility treatment.
So I guess this
So
is
yeah,
where
it
the
just
clinical eye
varies.
comes into the picture, that now it becomes an individualized care. When you think the patient is in a more stable state, that's when you kind of downgrade, and of course saving the budget, the financial budget also, when you mentioned about the expense. Because I have these patients who I started on pro. I just trying to figure out, like, when should I start now maintain them on the regular. So sounds from the sound of it, really this is more clinical. Is that correct?
Yeah.
Okay. And also, are they asking, can you overdose of this?
I don't think so, because I do know that when you get up to like the highest dose that people have taken really is 160 milligrams, and they took that for about 6 months. That there were really no issues, but if you accidentally take more than that, you will probably have GI effects. So to the point where you will not want to take any more.
Right, right.
So yeah, yeah.
So it's more GI. I just thought they're gonna have to be doing cartwheels like crazy when you have too much mitochondrial energy. So
Yeah, I don't think we've heard of people having too much mitochondrial energy. So yeah,
right,
I think
right. Okay.
it's yeah, it doesn't quite work that way.
Okay. This is a famous question for supplements and for absorption questions, I guess. Food without food.
Hmm? Oh,
With
who
food,
shouldn't
with
take them?
food or
Yeah.
without food.
Oh, without food, definitely. Oh gosh, yeah, this is so important. So the bioavailability of MitoQ goes down significantly
Hmm.
if it's taken with food. So we always recommend that people take it a half hour before a meal.
Oh, interesting. Okay. Because I don't know if that's the same concept for ubiquinol.
Yeah, it's
I'm just
completely
forgetting.
opposite. Yeah,
It
yeah,
has to
that's
be
why it's
with
confusing.
food.
Okay, there's a question about your contact information, Dr. Mitchell.
Oh yeah. So I can be reached by smitchell@mitoq.com.
Okay, the same place I get you then, right?
Yeah. Or you can go to this MCRP website and you can also just type in mcrp@mitoq.com and reach us through email there. Or there's a contact page on MCRP that goes directly to me. So any queries about, yeah, mitochondria research can go there as well.
We have a request from Kent. Can you show the first reference slide again?
Which one?
Can you show the first reference slide again? According to Kent.
These references.
There we go. Continue. Here we go.
Right.
And that's all my questions.
There we go.
So great presentation, Dr. Mitchell.
Yes.
Cool. Thank you.
Thank you so much. We're still waiting on our CME provider to see if they're back. So hopefully we'll be able to catch up on the last few that we've sort of missed. Anybody else have any other questions for Dr. Mitchell here? So okay, great information as always. And there was a question about any effects on telomere length, increased output of ATP, and any effect on autophagy.
Yeah, so has been shown preclinically to increase telomere length. So in mice and also in skin, which I thought was interesting. Seems to have some benefits for skin. Autophagy, not as much as mitophagy. So it does have mitophagy effects. I don't think I've seen as much autophagy, except for those examples of the clonal hematopoiesis.
Mm-hmm.
And then what was the last part of that?
Increased ATP output, telomere length.
Yeah, yeah. Mm-hmm. So we've seen increased ATP output mostly in issues that are, kind of, I would say, having an effect on ATP production overall. So it's not going to boost your ATP up in a normal, healthy organism. Like, let's make that clear. But, in an Alzheimer's mouse model or a model of heart disease or diabetes, for instance, in humans, humans that have chronic heart failure, we see the ATP production goes up in their blood cells, their white blood cells. So it's more like ATP production will go up if you're already a little bit compromised.
Okay.
Yeah.
Dr. Antoli says I take MMS and it gives me a lot of energy. I don't know what that is. Like ozone, she says. I don't know what MMS is. So I don't know.
So Dr. Mitchell, you mentioned about NMNH. Is that a new supplement? I haven't heard of that.
Yeah, that's coming into the market now. And I just find it hilarious that there's so much of this NAD precursor hype of just like, let's get as much NAD in your plasma, and that should be enough proof for you. And I hope that today was clear that it's not enough proof. I mean, every single clinical trial on NMM, NR, or this new one, this NMMH, improve NAD levels, but then I'm not seeing as much clinical data to make it think that that's doing a lot of benefits.
Yeah, Dr. Sinclair kind of jump-started that whole research about NR and the benefit. I think that's just how it snowballed now into all of these NAD supplements. And that's why they're like costing crazy money, especially for patients. And as you kind of put it out there that the medical literature really is not backing it up much. So that's really you're breaking hearts here. So I'm sure there's a lot of patients kind of like, wow, really? Their jaws are dropping.
Yeah. And I feel bad because I wish it was as effective as, oops.
All right. Okay. All right. Any other questions from on your end, Dr. Nario?
No, that's it. You got it all out of the ballpark.
Okay. Well, thank you so much, Dr. Mitchell, for being with us. Anybody have any questions, comments? You have any events coming up? Next week, it's still a little bit up in the air at the moment. So Dr. Klauser and I have a really good case history. I think we're going to present if our speaker that we're trying to get doesn't come through. I think you'll find it very interesting, and it covers pretty much the gamut of everything, most everything that we do. All wrapped up in one person. So we at some point we're going to do this case history where we'll present it to you, and maybe we can have a discussion on some different ideas about how to go about handling this. There's some autoimmunity in there, there's some infertility in there, there's some polycystic ovaries in there, and a couple of genetic issues also. So all wrapped up into one unfortunate person. So
Sorry, I'm back. I apologize. My internet just went out, so I'm just using my phone. But anyway, I'll just say goodbye to everyone because I think we're wrapping up.
Thank you so much.
You,
We'll
Dr.
send you the
Mitchell.
video, and I'll send you the participant list when we're done here. Okay.
Awesome. All right. Thank you.
Okay. Thank you so much.
Thank you.
Thank you.
Okay. All
Awesome.
right. Okay. Any final words, Dr. Nario?
So a little plug, shameless plug. March, we're going to be having our women's hormones, A4M. That's online. So visit our website and you can check it out for 3 weeks. We're going to have the whole program.
You will have the whole program with A4M on March?
It's going to be an online course for women's hormones. It's more for advanced.
And you're going to be able to get us a discount, aren't you?
I want to.
Sure, wink, wink.
Huh?
Wink, wink. We'll try.
You're going to get us. You're going to be able to get us a discount, right?
Definitely.
Or in trouble. One of the two.
That's a given.
Do you want to share a link for that?
Yeah. I'll send one out. I just have to find it. I'm always not in the loop when faculty matters. That's why I get in trouble for that.
Yeah. And I know in April, live online, Carol Peterson is part of it. So Lindsay Berkson is holding a breast cancer symposium, a 3-day symposium, and David Brownstein will be there, and Carol Peterson will be there, and a whole bunch of I had it up here just a second ago, and it's that a whole bunch of other famous people will be there too. So you're interested.
Pretty specific.
I had it all ready to go, and talk amongst yourself for a second.
I know them guys. For the Philippine group, I'll be speaking for the Medical City Conference. I think that's on June or July. So I'll probably be doing that online. So just I don't know if you guys know about it from the Philippines, but I'm going to be speaking there. Hopefully you guys attend live. It's a pretty good conference. I saw the lineup. So Philippine doctors hopefully support our integrative community.
Hey, Dr. Nerio, have you gone to the VA over in the Philippines by any chance? Or nobody
is there a VA there?
Yeah, that's what I hear.
Oh no, I haven't. That would be interesting.
Yeah, wouldn't it though? I'll have to go with you on one of the trips.
Let's go.
There is a functional medicine conference in February, at the end of February. Dr. Andrew, it's a speaker there. I saw.
Really? Wow.
Yes.
Dr. Andrew, and he didn't call me.
Bill Andrews.
And Dr. Robbins, I saw him there too, on the list of speakers.
First he stands us up on Sunday night for dinner, and now he's having a conference without us. I'm starting to get a little paranoid here.
But it's
Maybe he needs to drive early. Remember, he's the one driving cross country because he's worried about COVID.
It was 6:30. It was plenty early.
He probably started driving.
Dr. Klatsk has to go be in bed by 8. And so does Dr. Dayton.
So does Joel. I try still.
Yeah. All right, everybody. We'll get the videos ready for you, and we will be here next week, same time, same station. If Dr. Nerio can't find that speaker for us, we're going to do a case history that I think you're going to find pretty interesting. And with that, we're going to say over and out. Thank you all.
Good night.
Night, everybody.
Thank you.
Good night.
It's an honor as always. We'll talk to you again soon. Okay.
Great job, everybody. Bye.
Good night.
Bye-bye.
Good night.
Good night.
Bye-bye.